This conference will now be recorded.
హలో పవన్ కళ్యాణ్.
రాజేష్ చెప్పు. రాజేష్
Good morning. Sorry for the delay. Continuing with neuroendocrine tumors, pancreas, insulinoma, it is most common functioning tumor. Equitable distribution in head, body and tail. 97% are located in the pancreas, remaining 3% located in the duodenum, splenic hilum or gastrocolic ligament. Whipple's triad itself 2 marks question. Fasting induced neuroglycopenic symptoms of blood glucose level, hypoglycemia, low levels 42 ppm per deciliter. Relief of symptoms after the administration of glucose. 72-hour fasting test. High level of serum insulin more than 5 microunits per ml. Insulin to glucose ratio higher than 0.3. C-peptide levels higher than 1.2 micrograms per milliliter. CECT or MRI useful for diagnosis. Most of the times insulinomas may not detected in radiological scans. You have to confirm it intraoperatively by intraoperative ultrasound scanning. Hyperattenuating because of rich in blood supply. Arrow mark shows the insulinoma in the tail of the pancreas. Gastrinoma, second most common functional pancreatic endocrine tumor. Most common tumor turns into malignancy. After glauconoma, which is more common in men, produces Zollinger-Ellison syndrome. Hypergastrinemia, subsequent severe peptic ulceration, severe diarrhea. Gastrinoma triangle or Passaros triangle, most common location of the gastrinoma present in this triangle. The junction of cystic duct, CBD, the cystic duct joins to common hepatic duct to form the common bile duct. The junction between the second and third part of the duodenum. Junction between the neck and body of the pancreas. Most common presentation is abdominal pain. Diarrhea relieved by nasogastric aspiration by putting the Ryle's tube empty the stomach. So irritation of the gastric mucosa, bowel was reduced, so diarrhea is relieved. Symptoms of GERD: because of excessive acid secretion. Presence of hypergastrinemia in the presence of increased secretion of gastric acid. An elevated serum gastrin level coupled with pH lower than 2 in the gastric aspirate usual gastric acid pH is 2.5 to 4. Fasting levels of gastrin higher than 1000 picograms per ml. Upper limit is 100, but it is 10 times the normal level. An increase of more than 200 picograms per ml in the gastrin value after administration of secretin. Secretin is the hormone stimulation test. VIPomas release high levels of VIP. Werner-Morrison syndrome, also known as WADA syndrome, watery diarrhea, hypokalemia, echlorhydria due to loss of potassium. Pancreatic cholera is also called as pancreatic cholera. Pancreatic secretions usually contain high potassium levels. So leads to the loss of these secretions, leads to hypokalemia. Most of the times VIPomas are solitary. Larger than 3 centimeters. 75% are located in body and tail. Hypokalemia, hypomagnesemia, hypo or echlorhydria, class of chloride that is acidic nature. Hypercalcemia, deposition of the calcium. Class no class glucogonomas are very rare but most malignant. Tend to be larger, size of averaging 5 to 10 centimeters. Almost always arise in the pancreas. 65 to 75% found in the body and tail. Insulinomas equitable distribution, VIPomas body and tail. Gastrinoma out of the pancreas, that is Passer's triangle, mostly common in the duodenum. Glucogonomas common in the body and tail. Fasting glucagon level higher than 50 picomoles per liter is considered diagnostic. The glucogonoma syndrome, 4 days. Diabetes, dermatitis, deep vein thrombosis, and depression, 5th day is death. Sir, good morning, sir. Sir, sir. Sir. Okay, sir. Okay, sir. 11:30 కల్లా వస్తాను సార్. క్లాస్ చెప్తున్నాను నేను. Diabetes, dermatitis, deep vein thrombosis, depression, and death. 5th day is death. Migrating thrombophlebitis, it is characteristic of pancreatic tumors. That is, one of the tumor is glucogonoma. Most characteristic for glucogonoma is migrating thrombophlebitis. This diagram shows necrolytic, migrating erythematous dermatitis of glucogonoma syndrome. Somatostatinomas, these are solitary and 85% are larger than 2 centimeters. Glucogonomas are 5 to 10 centimeters. VIPomas are more than 3 centimeters. Mostly at the head of the pancreas. %90 are malignant. Steatorrhea, loss of fat in the stools, more than 7 grams per 100 grams of stool for continuous 3 days examination. It is diagnostic for steatorrhea. Diabetes mellitus, hypochlorhydria, and gallstones. Fasting somatostatin levels higher than 14 moles per liter. Associated with von Recklingh's disease and pheochromocytomas. Coming to the non-functional neuroendocrine tumors. Neuroendocrine tumors of the pancreas mostly non-functional. Only few are functional tumors. These non-functional tumors are defined as a pancreatic tumor of endocrine origin with no definable hormone syndrome. Because of non-functional tumors, there is no active secretions, so no hormonal syndromes or symptoms. Due to non functionality. The presentation is very late. By the time of presentation, these tumors mostly turn into malignancy and metastasize to the local or distant organ at the time of presentation. So prognosis is worst. These are identified by positive immunostaining for chromogranin A or synaptocin. Localization of the neuroendocrine tumors. Cross-sectional imaging with CT or MRI. This is the first step in localization. So first investigation is either CT or MRI. Mostly we can go for CT. If we don't find anything, then go for MRI. The sensitivity is 71 to 82%. This sensitivity is mostly depends upon the size of the tumor. Less than 1 centimeter tumors we can't find in both cross-sectional images. Location of the endocrine tumors is finding of location, localization of location is very much difficult. Vascular blush in the arterial phase is critical. In CT, triple phase contrast, arterial phase is critical for the diagnosis of endocrine tumors. Even in MRI also, attenuation of the image is hyper in the highly vascular tumors. Endoscopic ultrasound. The overall sensitivity of 93% compared with CT and MRI, it is better in diagnosing the neuroendocrine tumors. Sometimes it is useful to diagnostic purpose like biopsy. Greater sensitivity when compared with CT and MRI for detecting less than 3 centimeters tumor. Allows for FNAC. Somatostatin receptor scintigraphy. Not useful in insulinoma. For insulinomas, we use secretin. Because somatostatin function is against to the insulin. So not useful in insulinoma. The sensitivity for somatostatin receptor scintigraphy is 80% for all pancreatic endocrine tumors excluding insulinoma. For functional and non-functional tumors except insulinoma, the overall sensitivity is 80%. It has an overall sensitivity of 80 to 100% and specificity higher than 90% for gastrinoma. Show exact location of the tumor. But indicates its vicinity within few centimeters. Angiographic techniques and portal venous sampling. Sensitivity higher than 90%. Blind exploration with intraoperative ultrasound. Comparison of CT, MRI, somatostatin receptor scintigraphy in a patient with Zollinger-Ellison syndrome. In CT and MRI, no tumor was identified. But in SRS, showed a focus in the left lobe of the liver, while intraoperatively there is 1 centimeter left lobe liver metastasis and a small duodenal tumor of 0.3 centimeter gastrinoma with adjacent lymph nodes was identified. This SRS useful to diagnose the missed tumors which are less than 1 centimeter. Arteriographic demonstration of a insulinoma. Selective injection into the, that is contrast injection. Specific dorsal pancreatic specific pancreatic artery demonstrates tumor precisely. This round white tumor. Insulinoma with triphasic CT. In the arterial phase, this black arrow locates the tumor. The mass in the pancreatic body demonstrates early and prolonged enhancement with washout during the portal venous phase. Coming to the treatment aspect, the treatment of endocrine tumors is surgical. Is performed by the laparoscopic or open method. In general, procedures are pancreatic head resection, distal pancreatic resection, because most of the tumors present in the tail, body and tail, or tail, or enucleation. Generally, less than 2 centimeters tumors go for enucleation. For insulinoma, usually smaller and solitary tumors, enucleation was done. For metastatic tumors, streptozocin with or without 5-fluorouracil chemotherapy drugs. Gastrinoma, small, well circumscribed or well encapsulated tumors go for enucleation. Large tumors, unencapsulated tumors, require segmental resection. Including distal pancreatectomy or pancreaticoduodenectomy. For gastrinomas, radiotherapy and chemotherapy are ineffective. For VIPomas, glucagonomas, somatostatinomas, and non-functional tumors, because of this malignant nature, go for resection. Dicarbazine is uniquely effective against glucagonoma. Insulinoma, which is mostly benign tumor, so enucleation is useful and effective, but location is difficult. So location of the insulinoma was done by intraoperatively using endoscopic ultrasound or ultrasound. Gastrinomas, SRS is useful. VIPomas, glucagonomas, and somatostatinomas are usually larger tumors. And malignance transformation is very high. Most of the times these are malignant at the time of presentation. So surgical resection is useful, no treatment of the choice. For glucagonoma, dicarbazine is useful and effective. Thank you. This pancreatic topic was finished. Put your attendance in the chat box. Thank you.